Hey everyone, and welcome back to MedSnap RX. Today we're going to be talking about colovesical fistulas, how they develop, what are you going to see in your patient, and how we can treat them. So let's get started. So by definition, this is going to be a connection between the colon and the bladder. It's about 1 out of every 3,000 surgical cases a year, and it primarily occurs in the context of diverticular disease and Crohn's. 18% of your patients with diverticular disease will develop a colovesical fistula, and around 1% are going to develop it in the context of Crohn's. And remember, Crohn's is a transmural inflammation, which is what predisposes our patients to this. It's more common in males and females in around a 3-to-1 ratio. However, in females, if they haven't had a hysterectomy, normally that sigmoid colon that will develop like the diverticular disease or that inflammation will invade the uterus. However, if that uterus is gone, it can go ahead and touch the bladder, hence the colovesical fistula. And the mean age of presentation is around 55 to 75 years of life. So if you look at our spread right here, we have diverticulitis, cancer, and Crohn's colitis making up the large majority of the etiology pie graph. However, you can also have surgery, stents, or other inflammatory processes. So for the most part, it's just inflammation driving these cells to invade the bladder. But you can also have some mechanical problems as well. So if you look right here, there's actually a case report in 2013 of a colovesical fistula being caused by a chicken bone. So essentially the chicken bone went parallel down the GI tract until it didn't and perfed the bladder. So just because something's very common, don't rule out the zebras. Alright, so the most specific thing is pneumaturia. It's about 95% of these cases. It's whenever you pass flatus to the urethral meatus. So just remember that rhyme. It's gas coming out whenever patients are urinating. That gas sits at the top of the urinary bladder, and what happens is whenever you contract, the dense water comes out first. You experience puttering at the end of your stream, and they can actually hear like going through a balloon at the very end with some gas. And one of the other things they'll experience more commonly as well is fecal urea. So they'll say like it's cloudy, it's dark. It'll be like a chocolate colored urine. It's like fecal debris, vegetable matter, and some very cloudy urine. There's probably leukocytes in it as well, but it's going to be dark. Those next 3 symptoms that I have listed here are more of a UTI picture, and you'll see hematuria as well. About 1% of the cases will have it, and it's mostly associated with malignancy. So if you see gross hematuria, think malignancy, whether that's a primary colonic malignancy invading into the bladder or primary bladder malignancy. So how do we rule in or rule out? So you can get a urinalysis and a urine culture to check to see what is the bug that's causing these symptoms. E. coli is going to be the most predominant bug, so if you see this on a test or in clinical practice, think of that right before you think of anything else, and it's mostly a single species rather than a mixed flora around a rate of 40 to 70%. And now how are we going to image this? So there's essentially 2 ways to look at this. Do you want to see the fistula or do you want to see the underlying etiology? If you want to see the fistula, the gold standard, and for most of the tests, it's going to be an abdominal pelvic CT with oral or rectal contrast. And do not use IV contrast. So the reason that this is said is because the kidneys renally excrete IV contrast. And how can you tell whether if there's contrast in the bladder, it was micturated by the kidneys, or if it was a perforation in the colonic lumen? You can't. So you have to use oral contrast. So if you see contrast in the bladder at this point, that is diagnostic that there's a fistula between these 2 tracts. You can use like an endoscopy, a cystoscopy, or an enema if you want to parse out the exact etiology. They're a lot less sensitive than the abdominal pelvic CT. However, they will tell you, you can actually see that fistula when they're looking up on a scope. And direct cystoscopy, again, this is kind of our malignancy picture. Don't forget that 20% of our pie chart. All right, so we have 2 ways to treat. We can do non-operative or operative, but it's important to keep in mind that this fistula is not going to kill your patient. The sepsis will. So you need to use a quinolone with some metronidazole or augmentin. Again, we're targeting these gram-negative and anaerobic bacteria. Decompress your urinary bladder, not to put a lot of stress on it. If you do have that fistula, then you might want to rest the bowels too. So if we're going operative, we're going to resect that diseased colon, repair the fistula, and you take away some adhesions, you reanastomosize, and we'll talk about the arterial anatomy in a little bit, because there is a rare complication that can happen that might be tested. And for post-op, you're going to want to leave your catheter in for at least 7 days. It used to be 10 days, but the longer you go, the more likely your patient is to develop bladder atony because they're not actually pushing out that urine. You're going to want to gradually advance their diet, get them breathing, get them walking as quickly as they tolerate without pain or reasonable pain, because a lot of times these patients will have pain because they're essentially breaking up these adhesions that are starting to form and the wound healing process that is taking place. So you can have this anastomotic breakdown, which is what happens whenever you accidentally cut arteries either too far into their blood supply or not enough. You can have a pelvic abscess, but this is rare. Just look for signs of inflammation and obstruction. You can have bowel obstruction/dysfunction. This is the most common thing that's going to happen. And then healing is going to take around 3 to 6 weeks, so just make sure you tell your patient. All right, and here's the arterial anatomy of the colon. It's extremely important to know that whenever they're doing like these left anterior resections, which is most commonly the site of these diverticulum that are causing these fistulae, you're going to want to make sure that they clamp that IMA but leave in contact some of these marginal arteries. So if I can go ahead and actually show you right here, most of the time they're going to come up right here to the splenic flexure, which again, remember, is in a watershed area. And this is the proximal cut, which will be the proximal site of the anastomotic point. And then they'll come down to the rectum, make another cut as well. And this is additionally another watershed area. So this entire portion right here is supplied by the IMA, and the arteries that we're trying to leave intact are these marginal arteries. So they'll go and they'll actually take down adhesions all around the sides. It's a lot more nuanced than what I'm doing because you kind of want to spread out windows as well. But then these two parts actually come together. So just keep in mind for the test, those two red lines that I made, those are some watershed areas. You're clamping the IMA, but you still want your SMA and the perfusing branches from the iliac artery to perfuse your newly anastomosized colon as well. And that anastomotic breakdown can break down because you didn't give it enough arterial flow. Okay. Alright, so if you don't remember anything from the video, remember these points and you're going to get it right on test day. Treat your patient, not the disease. If you have a patient that has recurrent UTIs, 55, 75 years old, male diverticulosis, suspect a fistula. If your patient says, I'm passing flatus through my urethral meatus, that is 90 to 100% specific for these fistula. Please remember that. An abdominal CT with oral or rectal contrast is your gold standard for the test. A barium enema/colonoscopy can be used to parse out the etiology if you need to. Treat your sepsis first because the fistula won't kill your patient, and plan for a surgical repair with both urology and colorectal surgery. It's going to take about 3 to 6 weeks to heal, and please look for signs for the anastomotic breakdown. Alright, this is all that you need to know about a colovesicular fistula. If you have any questions, please put them down in the comments, and thanks for watching.